yes, so we may then start. So just to say that the first thing is that I do not have any disclosures. So, you know, I love teaching and I love HIV medicine. So I'm just going to give you my understanding of different topics in HIV and share with you without really worrying about any conflicts, you know, of interest. By the end of this session, you should be able to assess and investigate a patient who presents with a suspected kidney problem, particularly if they are HIV positive on ARVs. You would also start to understand the mechanisms under which tenofovir-associated nephrotoxicity happens, and then a pragmatic, because if we just discuss theories without really guiding to say, if you have a patient, this is how you approach the patient, we would have missed the purpose of these particular sessions. Before I start, I just want to check on you, you know, just let me know, you know, how you are feeling today. You know, it's a new year, it's on a Thursday, you know, how is your mood today? There should be a question in front of you. Are you happy? Are you just okay? Are you sad? Are you not sure? We are health workers. We are always, you know, overburdened, and it becomes a challenge sometimes. All right. So I'm going to end it there and just share with you that most of us are happy and okay. No one is feeling sad today. There's a few people who are not sure. So yeah, so even if you are not sure, I hope by the end of this session, you know, God gives me the energy to really inspire you and inspire hope in your life. So here's a scenario of a 27-year-old female who presents to you with diarrhea, fever, and weight loss. She is HIV positive. Her CD4 count is 95. And she was started on ARVs, TLD, tenofovir, lamivudine, dolutegravir, a week before, right? And you are seeing her at a primary care. So this is not at a big, you know, hospital. So one of the first questions I have for you to say, as you evaluate the 27-year-old female with diarrhea, fever, you know, and how she's presenting there, do you have any particular assessments, you know? And my question to you really is to say, looking at her blood results there, she's got the urea of 19, so that's from the UNE. She's got a creatinine of 442. She's got a potassium of 6.7. You know, in your initial assessment, you know, of this patient, what type of kidney injury do you think she has? You know, does she have acute renal failure? Is this chronic renal failure? It's also possible that you are not sure, but what is your view or your initial assessment of this patient? All right. Let's all participate so that we are all engaging. And Dombi, I see you are saying you are tired. Yeah, it does happen. It's early in the year. Some of us didn't take leave or time off, and we can feel a bit overwhelmed. So as you can see, most of you saying it's acute. We will discuss whether that is true or not. Around 30%, you are saying this is chronic renal failure. And then some of us are not sure, which is also a good thing in medicine to know when you are not sure, so that you can refer. So I'm going to continue. So firstly is for us to appreciate that acute kidney injury is common, right? I mean, I get calls. Even yesterday I got two. I think today I got one from Amajuba as well, in a maternity of a pregnant woman who's on ARVs, who presents with some form of kidney injury. So it's something that is common, but however, it is reversible. And then if we do not act in time, it can be associated with mortality, you know. So kidney injury is a very important medical condition that we need to monitor. And then HIV, either directly or indirectly, can contribute, you know, to both acute and chronic kidney disease. And therefore, we need to be able to respond timely and effectively when our patients present with some form of kidney injury. I won't go into the details, of some of these criteria for assessing acute kidney injury. What is very important is that we need to spend most of the time, identifying our patients who might be at risk of rapidly deteriorating, their kidney function, and probably intervene, at this particular time. Because more than half the time, when we say someone has been picked up, we are suspecting kidney injury, we find that it's already too late. Half the time, patients have already lost most of their kidney, function. So if you have a patient who has a slight increase in their creatinine, they have a slight decrease in the glomerular filtration rate or your EGFR in the HIV space, or they are not passing enough urine based on their weight. So, you start to think this person is at risk of kidney disease, and let's start to monitor them very closely, giving them appropriate nutritional advice, but also reviewing some of the drugs and other things that might be contributing to this change in kidney function. However, if we identify patients a bit late, more than half the time, we are unable to help them that much. So this is the rifle criteria. There's also the Aiken criteria, but if you look at these criteria, they're relatively the same, right? The whole idea is that you can stage kidney disease into different stages. We always prefer to detect it very early, and particularly even before we can even say it's stage 1, by just properly assessing our patients, taking a proper history, identifying drug toxicities or behaviors that might increase the risk of kidney injury, and then dealing with modifiable factors in time. So that is quite key. Another important issue about kidneys is that especially in the HIV/AIDS program, we tend to monitor kidney function by regularly collecting blood for a creatinine test, right? Whether the serum creatinine or even the calculated EGFR. It's important to note that most of the time, the creatinine would remain normal until at least a patient has lost 50% of the function of the kidneys. That's very, very important to note, that the serum creatinine is not a very reliable test to picking up early disease. By the time a patient starts to present with an abnormal creatinine level, they've already lost more than half of the function of the kidneys. So we need to start to look at other ways of monitoring kidney damage for our patients. So looking at our patient here, we'll still discuss the issue of acute or chronic shortly. If you see a patient like this presenting with diarrhea, she recently started ARVs, her urea is 19, her creatinine is 442, and she has a potassium of 6.7, which is high as well, right? What are some of the things you might want to do? What would you consider as your initial management of this patient? I've given you some options. You can type if you have additional things you want to do. We will get into the details shortly, but you may actually choose more than one answer on this particular question. Let's all try to participate. All right, I see you are thinking about it. Thank you very much. I'll give you 2 more seconds just for us to have a discussion. All right, I'm going to stop and show you your results. So most of us say they will classify, assess, and investigate the cause. Rehydrate the patient is probably because of the diarrhea. I see an equal number says they will stop TDF, and a small percentage says they will stop all ARVs. So yeah, quite interesting. I'm hoping that by the end of this session, we will all, be on the same page around how we approach this case. So your initial assessment is made up of these 8 or so steps, right? We need to say, are we dealing with an acute or a chronic problem? And then where is the problem? Is this pre-renal? Are we talking about something in the kidneys or post-renal? And then how bad it is, because remember the severity determines whether you are admitting, whether your patient needs dialysis, and so on. And then, is your patient stable? Obviously, the stability and severity, they go together. What are some of the most likely causes? What additional tests you can do? Then you respond with your initial management. So basically, on that questionnaire, which I had just posed, the issue of classify your patient, assess how bad it is, investigate and treat. Probably that's the best, approach for our patients. So how do you differentiate between acute and chronic renal disease, right? So if it's a known patient and previously their creatinine clearance, their EGFRs were normal, the UNE was normal, and suddenly today it is abnormal, most likely you are dealing with acute, renal kidney injury versus a chronic kidney injury, right? If the kidneys are normal, most of the time we don't do sonar in a primary care. So if they are referred, you do a sonar, the kidneys are normal, there is no anemia. So the presence of a low HB will sort of give you a sign that maybe you are dealing with a chronic renal problem, hyperkalemia, no comorbidities, and a short duration of symptoms. So if we go back again to our case, right, if you look at it, we started her on ARVs 1 week ago. One can presume that she was okay 1 week ago. Today she's not okay. She's got a high potassium and some issues around the kidneys. But in addition to that, she has diarrhea. So there's a specific cause, and which is a recent cause. So most likely, if you were to decide whether our patient is acute or chronic, you are likely to say the patient has acute kidney, injury. Obviously, as you investigate, if you identify that the kidneys are small or there's other things going on, like she's anemic, she's got other comorbid conditions, whether diabetes or hypertension, or she once had this, except that it was not checked previously, then you might still change your mind. But based on the minimum information we have, we can sort of agree that the patient has acute kidney injury, right? Then since we agree that this is an acute kidney injury, the next thing is to say, where is the problem? Are we dealing with a pre-renal situation? So if we put the kidneys here, are we talking about something that happens before the kidneys or after the kidneys, right? So pre-renal, generally you would have a significantly higher urea than your creatinine, and most of the time it's caused by hypoperfusion. So your kidneys are not getting enough, blood supply, usually volumic shock, hypotensive conditions, septic shock, anything that would limit the blood supply to the kidneys would generally be regarded as a pre-renal condition. Sometimes there's a direct insult, something that causes direct kidney injury, whether it's drugs, whether it's herbal, medicines that people are taking, infections, viruses, cancers, cysts, anything that affects the kidney, directly, right? Then you've got your post-renal situations. Most of the time, it's things that obstruct, your kidney. Somewhere, a male patient over 40 years with prostate cancer who presents with urinary obstruction. Now there's backflow to the kidneys. The kidneys are getting injured. So that's how it works. I think what is key as well is that the differentiation between pre-renal and the intrinsic renal kidney injury, sometimes it's a very thin line. They tend to coexist as well. If you look at a hypertensive patient, right, they might start to have hypoperfusion first, and later on they've got kidney ischemia as well. So these things can really relate sometimes, right? Then once you have determined where, the problem is, like in our case, we're talking about the patient who was okay, they are now having diarrhea. And if we think the issue is dehydration, it's like we're probably considering a pre-renal situation, but you have to investigate and examine your patient further to see if there are no other issues. By the way, she's also HIV positive. So if you look at HIV-associated nephropathy, that would be an intrinsic issue. So depending on the final assessment of our client, we might then decide otherwise. Then we have to say how bad it is, like in our case, there's hyperkalemia, the potassium is high, but it is not very high. It's something that we can still try and correct either through admission and so on. Is your patient acidotic? Is he struggling to breathe? There's pulmonary edema, bleeding tendencies, or even confusion. So if your patient has any of these complications, they probably need to be admitted. They are likely to need dialysis because whatever is going on needs to be resolved as urgently as possible. So quite important. Then what are some of the causes? So your causes will follow our earlier classification. So if you are thinking this is pre-renal, are you dealing with shock of some form? Has your patient lost blood, acute blood loss, dehydration, hypovolemic shock, septic shock, renal artery stenosis, limiting blood supply to the kidneys, and some of the drugs that are known to be, nephrotoxic as well. So quite a number of things. In our scenario where there is diarrhea in a patient who was previously well, start with the easy things to do. Let's rehydrate and correct and see if the patient gets better, or not. In terms of intrinsic, it's actually a whole lot of conditions beyond what you are looking at here. Renal ischemia, usually as a result of, pre-renal issues where now the kidneys are not getting enough blood supply, sepsis, hypertension, nephrotoxic drugs, tenofovir, your amikacins, gentamicins, amphotericin B for the treatment of cryptococcal meningitis, and many other drugs. HIV-associated kidney disease, which can be HIV or HIV, glomerulonephritis, interstitial nephritis, either due to drugs or even direct insult by some of the infections, hemoglobin. So a whole lot of conditions that can cause, acute tubular necrosis leading to direct kidney injury. On the post-renal failure side, you can get renal stones, urinary tract infections. Schistosoma can also cause blockages, strictures where there's healing by scarring, blocking there. If a patient has a pelvic mass, sometimes even your cancer patients, cancer of the cervix, if it's the spread, the bladder, prostate cancer. So anything that blocks urine output would be regarded as a post-renal cause, which are generally unlikely for our case, but it's always good to do your investigations and check. Are you still with me? Please do type in there in the chat box and say, hi, doc, we are still here. We are listening or absorbing. But yeah, I'm hoping you are following as we continue. So I said earlier, nephrotoxic drugs, we cannot reduce them to a slide. It's a lot, but some of the commonly used drugs, your NSAIDs, your ACE inhibitors, the same drugs that you might want to use sometimes to improve kidney function can actually cause injury. So it's a very difficult thing to balance sometimes. Diuretics, your aminoglycosides, a whole list, and antibiotics as a class. Thanks, Marianne, that you are following, Bali. I like that. Thanks, Busi. It's always good to check on you. Now I need you to, now we are tenofovir, one of the drugs that the patient is taking, and we have also listed it somewhere there as a nephrotoxic drug, and we use it all the time. Thanks, Walter. I see you there, Mrs. Busi, so I appreciate it. So this graphic presentation is meant to explain, how tenofovir toxicity happens, and I want to explain a few things to you. One is that when a patient takes a tablet called tenofovir, you must always remember that that is a prodrug, right? Thanks, Dr. Kalani. You must remember that that is a prodrug. It is not necessarily the active form of the drug, right? So from the gut, a patient will take a tablet, then it is absorbed into the plasma. You can see in the plasma, most of the prodrug in terms of TDF is converted to the active drug already in the plasma there. And if you have higher concentrations of the active drug in the plasma, you are also going to have higher concentrations of the active drug intracellularly. We are looking at the proximal tubule of the kidneys, right? And the transportation of this active drug from the plasma into the cells of the tubules is facilitated by this organic acid transporter. We call it OAT1. So it's a transporter. It takes it from the plasma, puts it into the cells. In the cells, if there's high concentrations of the active TDF, they would then destroy, your mitochondria by blocking, the DNA synthesis process. Once we have mitochondrial injury, we then end up with tissue hypoxia. So you get necrosis. That's why we generally say TDF causes acute tubular necrosis, because the cells are not getting enough oxygen because the mitochondria are being destroyed. And then under normal circumstances, you would then expect the TDF to be excreted in urine using your MRP2 and 4, right? However, these receptors can be injured because the mitochondria are injured. Then you have accumulation of TDF in the tubules. Then, it's a cycle where now you have an ongoing cycle of absorption, retention, destruction of your mitochondria, tissue hypoxia, and more problems. So if you think of it, if a patient has a low EGFR, right, that is likely, to increase plasma TDF levels. So because of dehydration or whatever the issues are, remember, if your GFR is decreased, it means the excretion is slowed down. Then you have high concentrations of TDF in the cytoplasm, in the plasma, sorry about that. And high concentrations in the plasma translate to high concentrations intracellularly, leading to further damage, and then, making your kidneys, to not function correctly. So and then why am I talking about these receptors? It's important to also know that any other drug that the patient might be taking with TDF, which would either fast track the absorption of the active TDF or block the excretion of the active TDF, is likely to potentiate, the nephrotoxicity of tenofovir. Very nice graphic presentation that I like, and we will come back to it. So I won't go into the detail, but at the pathophysiology level, just remember that tenofovir inhibits the mitochondrial DNA polymerase. That means it destroys the synthesis of DNA, then destroying the mitochondria, leading, to tissue hypoxia. Then you've got your acute tubular necrosis, and your patients presenting with increasing creatinine levels, if not kidney failure, depending on when they are picked up, right? It's also important that when the proximal tubule is injured, now the function of the proximal tubule, amongst many other things, it's reabsorption of essential proteins, things like glucose, your amino acids, So if the proximal tubule, where tenofovir is supposed to be absorbed, is destroyed, right, because of tenofovir toxicity, you've got failure to reabsorb protein. So that's why you might find protein in urine, right? But it's important to note that generally at the tubular level, the issue is with your low molecular proteins, right? Why am I saying this? Because we must always remember, we generally use a urine dipstick to determine proteinuria, generally in our primary care clinics. And if we don't find anything there, then we say, no, the patient is fine. But remember, our urine dipsticks are designed to detect what? Albumin. Very important. But with tenofovir toxicity, your patient is losing what? Not albumin. Albumin levels would remain normal, unless if it was a glomerular kidney injury, but tenofovir injures the proximal tubule. The only proteins you would find in urine most of the time is your low molecular protein. So there's a very high chance that a urine dipstick would not pick up, especially very early, a patient who's got tenofovir toxicity, because there's no albumin in their urine, right? So then they can get, as part of what we call Fanconi's syndrome, where our patients can present with proteinuria, glucose in urine because the kidneys can't reabsorb glucose. You can pick up amino acids and phosphate in urine, then we call it Fanconi's syndrome, and which we will still discuss again. So I spoke about the importance of picking up patients who are at the risk of developing this kidney toxicity. So if someone has chronic kidney disease, maybe avoid giving TDF. Someone who's of an older age, maybe avoid advanced HIV disease, vascular diseases, patients who are taking other nephrotic drugs, someone who's got a low body weight. If you read in our guidelines, they always talk about an elderly patient who's got a weight less than 50 kgs with a creatinine above 100 as patients who are at a significant risk of developing tenofovir toxicity. And there's those who have a genetic predisposition, especially our Black patients. So we always have to see, but we don't generally do genetic studies in our primary care and hospitals. All right. If you have any questions, please do type in the chat box. Now, this is a graph. I will just keep it simple for you. All I want you to see here is that most of the time, if a patient experiences a tenofovir-associated toxicity, the performance or the functioning of the kidneys resolves after you discontinue TDF. And as you can see, if this was a patient who started with a very high creatinine, TDF stopped, you see a significant drop, over time. But what I need you to pay attention to is that very few of these patients, right, would recover to their pre-treatment, their pre-tenofovir level. So even if, yes, at some point the creatinine was 800, you stop TDF, some patients, they never get back to their fully functional kidneys. So patients with previous tenofovir toxicity, we must continue to monitor them as exposure to other nephrotoxic drug might potentiate, kidney injury later on. I spoke about proteinuria with tenofovir toxicity, and I wanted you to differentiate proteinuria from a glomerular injury versus from a tubular injury. Very important. With glomerular proteinuria, you'll always find albumin in urine. With your tubular injury, like the one that is caused by tenofovir, the proteins that you find in urine are your low molecular weight proteins. Now, the only reason why I brought this slide is to emphasize that a urine dipstick more than half the time would be normal even when a patient has tenofovir toxicity, because in the urine, if there's a pure tubular injury very early on, you wouldn't find albumin, which is usually what is picked up by our urine dipsticks. So firstly, I started by saying by the time a creatinine level increases, your patient has lost 50% of the kidney function. So a creatinine will always pick a kidney injury very late. Then I come back to you and say the next thing which we use is a dipstick. A dipstick with early tubular injury is likely, to remain normal even when the patient has tenofovir toxicity, right? Esther, you are asking there if a client presents with a creatinine of 40 greater. Oh, yes. So that is normal, Esther. I think it's the differentiation between a creatinine level and a creatinine clearance, right? Remember, your clearance would always be abnormal if it is less than 60 in our lab tests, right? Then your creatinine level in the blood, your serum creatinine is abnormal. Generally, if it's above 90 or 100, then we say you have a high creatinine level. So remember, the creatinine level measures how much creatinine do you have in the blood. Your eGFR measures the ability of your kidneys to function and excrete toxins, including creatinine, right? So when a patient presents with a creatinine of 40 and a creatinine clearance above 60, that means they have good kidney functioning, right? But if the creatinine clearance was less than 60 or the creatinine has crossed 90 or 100, then you start to become worried that they might be coming up with something that is injuring their kidneys. All right. So in today's world, really, I want to encourage you that where you suspect tenofovir kidney injury, just collect. You don't need a 24 urine specimen. In the early days, we used to admit patients to collect their 24-hour urine. There's still a place for that, but today's world, there's a better way. You just collect a spot urine, urine from your patient, and you send it to the lab. You ask them that you want to check the urine protein, the urine albumin, and then also your urine creatinine. What you're looking at, what you want to calculate is your urine albumin to total protein ratio, right? Urine albumin, so it's a ratio between what proportion, so for the proteins that are in the urine, what proportion is albumin, right? Because this is based on that discussion we've just had when I said, if it's a tubular injury, you will find that your total protein is significantly higher than your albumin. Your ratio will be less than 0.4. Then you know this is tubular damage. So you're looking at things that can cause acute tubular necrosis or injury. If you find that your albumin to proteinuria is more than 0.4, you're looking at the glomerular etiology. So you're looking more at the intrinsic issues, things that can really cause glomerular nephritis, your high veins and many other conditions right there. It is quite sensitive. And way better than looking at the creatinine alone or just doing a urine dipstick. So you collect in that bottle and you ask the lab to do the ratio for you. And if it comes back less than 0.4 or more than 0.5, but still less than 0.6, you think something is going on. However, if it's above 0.6, you start to think, no, my patient, he has a very, and remember, you are supposed to do, that's another important thing. You should be doing an albumin to protein ratio when your patient has abnormal, UNEs. Because if you randomly do these tests without checking, you start to interpret things wrongly. So quite important. Yes, Dr. Kakani, you will get the slides as the master class. And then if you are a member, you will get access to the video. You'll get access to other resources, including the slides. So I promise that this time you will surely get them by tomorrow. All right. So when we look at tenofovir nephrotoxicity, we classify it as acute. So tenofovir can cause acute renal failure, where patients present with high potassiums, rising ureas, and in a patient who was previously okay, or a Fanconi syndrome. I think by now you know why that is, because we said the active form of your TDF injures the mitochondria in your proximal tubule, leading to acute tubular necrosis. Your proximal tubules would fail to reabsorb your glucose, phosphates, and amino acids. So if you find glucose in urine, phosphate, you start to think, can this be tenofovir, right? It can also lead to nephrogenic diabetes insipidus, where the kidneys are failing or not responding to your diuretic hormone ADH. That means your patient will fail to reabsorb water as well. So if someone fails to reabsorb water, how do they present? It's as if they have sugar diabetes, but they don't have sugar diabetes. They have nephrogenic. The sugars are normal. Your blood sugar is okay. Your HbA1c is okay. But the patient says, I drink lots of water. I pass lots of water as well. But you exclude the diabetes mellitus, and then you investigate further to exclude. So this is the syndromes or how TDF toxicity can present. So remember, like I said, in our guidelines, anyone with a weight below 50 kgs and age above 50 years, a creatinine above 100, they are regarded as high risk for tenofovir toxicity. So pay attention to patients who meet these three criteria right there. And then in terms of monitoring, our guidelines say before you start TDF, do your creatinine and then repeat it at 3 months, 6 months, and 12 months. Still do a protein, a urine dipsticks, especially before you start, because if your patient already has proteinuria, before you start them on TDF, they become a high risk patient. We rely on a creatinine clearance, and generally a creatinine clearance of less than 50 would sort of be a red alert that please avoid the use of TDF in these groups of patients. And then you will see there that in terms of kidney damage and where you are put in a corner where you cannot stop TDF, right? You can still use TDF when patients have creatinine clearances below 50, but it should be in a control. It should be a patient where really you don't have options. Maybe they have hepatitis B, it's a very complicated case, but then you would need to renal dose adjust your dosing for, remember, under normal circumstances, we give it as 300 milligrams daily. So if the creatinine clearance is between 30 and 49, you would rather give TDF every second day. If it is 10 to 29, you would then give TDF twice a week. And then if really your patient is on dialysis and really you can't stop TDF, you have a serious clinical indication, you would have to give it once weekly. So we don't recommend this in stable patients. We prefer that you switch them. And how do you switch? You have a patient who's taking TLD, they develop early signs of kidney injury. It's best to stop TDF and give them abacavir. Where abacavir is not available for whatever reason, then zidovudine would be an option. So we generally don't recommend continuing tenofovir in the context of a patient who's not doing well in terms of their kidney function. Ms. Beta too, you are saying you're not a member. Will you be able to get the recording? Yeah, it's cheaper to be a member. I think it's cheaper to be a member. We'll discuss it again towards the end. I encourage you to be a member. I'll share with you the benefits and you would see. Just remember the issue of renal dose adjusting. It's not just a tenofovir issue. All drugs that are metabolized through the kidneys, particularly your NRTIs, would need to be adjusted based on the kidney function, of your patient. You see zidovudine, once the creatinine clearance drops to less than 10, rather than to give 300 milligrams twice a day, you would then omit one dose and it will be a daily dose. Lamivudine already, as soon as the creatinine clearance drops to below 50, you must not be giving 3 BD or 300 milligrams daily. Already you have the dose, emtricitabine, stavudine. The only NRTI that is quite safe, you don't need to do any dose adjustment, it's abacavir, because it goes through a dual metabolism, both by the liver and the kidneys through glucuronidation. So with abacavir, you can use the full doses, 600 milligrams daily or 300 milligrams BD, irrespective of the kidney function of your patient. All right. So the take-home points around tenofovir is that tenofovir causes tubular damage, and this leads to tubular proteinuria, which may be missed by a dipstick, right? It's always good when you have such patients to collect that spot urine and ask for a urine protein albumin creatinine ratio. And then if that ratio comes back to be less than 0.4, you then presume that your patient has tubular damage, not glomerular damage, and likely to be TDF. And then you discuss or you manage your patient based on your capabilities at your level there. Most likely switching would be the best approach. I'm sure you have heard that there's a tenofovir alphetamine. Yeah, tenofovir alphetamine. Bear with me. I hope you are laughing at me there. This is not English. It's just the name of a drug. TEF is quite, this graph for TEF and for TDF, they're quite different. And I'm not sure if you remember the TDF one. I can't remember whether the next slide is the same graph, but I'll show you. So if a patient takes TEF, right, which is meant really as an alternate to TDF in terms of patients who are at the higher risk of developing renal toxicity, rather than using TDF, you can actually use TEF, right? But what you see, remember TDF at that time, when I showed you this similar graph, was that if a patient took TDF as a prodrug, most of it would be converted to the active drug in the plasma already, right? But what you see with TEF is that the patient takes the tablet as prescribed in the gut, it is absorbed, it is still the prodrug in the plasma, very small amount of the active drug in the plasma. Let me see the next slide. Yes, if you compare tenofovir, you'll see that most of the tenofovir is converted to the active drug in the plasma. You get higher drug concentrations in the plasma, leading to higher concentrations of the active drug in the plasma, which then potentiates the injury, right? When you go, if I go back to TEF, you have the prodrug, it is absorbed still as the prodrug. You get some drug in the plasma, though the majority of the TEF will be converted to the active drug intracellularly, right? So really the difference between TEF and TDF is that with TEF, you get you are able to suppress the virus, right, with a fewer concentration or a lower concentration of the active drug in the plasma. I mean, that is the difference. Therefore, with TEF, you get a smaller concentration of the active drug in the plasma, leading to smaller concentrations in the tube. Yes, there might be some mitochondrial toxicity, but it's not common because you are able to get the right concentrations there and it is excreted, as needed. However, going back to TDF, you've got high concentrations in the plasma, in the cells, leading to mitochondrial toxicity. Then it becomes a chain leading to acute tubular necrosis. So sometimes for those who are working in the private sector, tenofovir alpheramine is probably one of the options that you can use in the context of high risk. You have a diabetic patient who needs, a better regimen and they can afford TEF. Maybe that's the drug that you can use. All right. I need also to show you, remember I spoke about it earlier on, maybe let me go back, that the active drug is transported by these OAT transporters into the cell and excreted by this MRP transporters as well, right? The proteins outside into the urine. Now, it's important to know that certain drugs that the patient might be taking may potentiate, renal toxicity. If you look at dolutegravir, I'm sure all of us, we know that our patients who take DTG, they have this slight increase in their creatinine levels. And we always say, it's not a very, something you should be worried about. It is generally temporary. And later you're asking an important question, can TEF be used for patients with hepatitis? And the answer is yes, it can be used in patients with hepatitis B because it's got the same chemical structure. It's just that the prodrug becomes converted to the active drug, most of it intracellularly and not in the plasma compared to tenofovir. So it's got fewer renal toxic side effects compared to tenofovir. So in terms of creatinine, if creatinine in the blood, it's supposed to be excreted via the OCT2 protein there transport system. There is in the cell, then it must go into the urine. But there's drugs that can block that receptor there, like dolutegravir. So how does dolutegravir affect the kidneys? Is by blocking, the metabolism of creatinine, for lack of a better way, by the proximal tubule right there, which is quite important. But other drugs as well, like corbistat, which is generally used with ARV drugs that need to be boosted, like your atazanavir, and sometimes the same TEF, for you to get a better effect for TEF, it needs to be boosted. So yes, TEF might have a lesser risk for renal toxicity, but because you want sometimes to boost it with corbistat, which then can potentiate toxicity, because it would also block your OCT2 receptors or transporters right there, right? You look at the Bactrim as well, which we use so much of it. We use a lot of Bactrim in practice for our patients. So a patient might be doing well, but because of Bactrim will block the excretion of your creatinine because it blocks those specific transport proteins, then your patient can have significant rises in creatinine. So you need to know that there's other ARVs as well that, ARV drugs that can affect kidneys significantly. So DTG in trials, we know that it's documented. It leads to small increases in the serum creatinines, right? And the increase in the creatinine generally appears in the first week. So usually if you start someone, you had the baseline creatinine, later on it goes up with their own DTG. The nice thing is that it does not go up and up and up. It goes up, then it's flat. If your creatinine continues to go up and up, you should be looking at whether this is not tenofovir toxicity. And it's important to know that dolutegravir has no effect on the glomerular filtration rate. So ultimately, it does not lead to renal failure or acute or even chronic kidney injury, right? So in our guidelines, you will find this, that patients who are taking DTG might experience an increase in their creatinine. It happens very early, not very late. However, this is not an indication to stop DTG. So DTG is not a drug to be stopped in the context of kidney injury, quite important. A drug like atazanavir, which we use as an alternate to lopinavir, it does not affect the kidneys directly. However, patients can get atazanavir stones, right? Nephrolithiasis. So most of these patients might present with pain, or even your post-renal symptoms where there is obstruction, depending on where the stone is, right? What is important is that once you stop atazanavir, most of the patients, they do well, but you must also know that patients might get new stones even after atazanavir has been stopped. So very, very, very important to note right there. All right, as I get closer and closer to the slides, to say now risk factors, how do you classify them? Very important to identify patients who might be having specific genes, especially your POL1 gene. It is significantly associated with conditions like your HIVEN in HIV positive Black males, socioeconomic, demographic, the age, your older patients, your Black African patients who are using illicit drugs, poor social status, exposure to comorbid conditions, especially diabetes and hypertension, obesity, malignancies, HIV that is not controlled. Patients might get the HIV-associated nephropathy, co-infections with hepatitis B, TB, especially your schistosoma there, quite important. Sometimes we forget about such things in South Africa. And then underlying HIV-associated nephropathy, focal sclerosing, glomerular sclerosis, immune complex diabetes, atherosclerosis. So you have to do a thorough assessment of your patient, and you need to get to some kind of a suspected diagnosis, which then you can investigate, most likely requiring, a biopsy as an important intervention. There's a patient which I discussed with the doctor in Amaju, and I said, this one needs a biopsy. You can't play guesswork. So in HIV, we talk about HIV-associated nephropathy. So HIV directly, causing an insult on the kidneys. What is very important, the reason why, if you look at this presentation, if I was to do this presentation like 10 years ago, for argument's sake, the first slide would have been on HIVEN. We'd be talking about HIV-associated nephropathy, and we wouldn't be talking about spending 20 slides on tenofovir. Why is that the case? Because the disease has transitioned. In the early days, people used to present late. We had the people presenting with CD4 counts of 1, very high viral loads. Therefore, HIVEN, HIV-associated nephropathy, was the #1 issue that we needed to deal with. In today's world, people are presenting early, there's universal test and treat. Now we are dealing more with nephrotoxicity or kidney injury due to the drugs, rather than seeing patients presenting with HIV. But you still get people who present late, who can present with these conditions, right? So it's a triad really, where there's collapsing, the glomeruli are collapsing, there's interstitial inflammation, microcysts, and also tubular injury, right? The other common type, or the other name, is focal segmental glomerulosclerosis. Like I said, generally associated with this particular gene, APOL1 gene, particularly in African Black males, right? How you manage it at a high level, just keeping it high level, ARVs. You start ARVs, you are likely to win. You might need to add ACE inhibitors because most of them, they have very significant proteinuria as well. There's people who used to believe in steroids, but there's no science behind it. Sometimes people use it, but for the autoimmune HIVIC, the steroids might play a role. And then other general kidney care, like if the patient is hypertensive, they need to be treated. Check their cholesterols, they need to be treated. If they are diabetic, the treatment needs to be optimized, and then also deal with the lifestyle modification issues. There is another complex, HIV immune complex kidney disease. I can tell you, in the olden days, we were allowed to just say, my patient has HIV immune HIVIC, as we used to call it. But I can tell you, the nephrologists, their congress, they've resolved that it's not good enough, because when you say HIV immune complex disease, you're talking about at least 5 conditions. It could either be IgA, isolated IgA nephropathy, post-infectious glomerulonephritis, post-streptococcal glomerulonephritis, a lupus-like nephritis membranous. So you can see that these conditions, each is unique, right? And it requires that a diagnosis be confirmed so that you can give appropriate treatment to your patient, right? So the reason why I've put this slide is to remind us that where a patient presents with blood in urine, and you've got casts, and they've got protein in urine, a nephritic type of a picture, always refer your patient for a biopsy, a kidney biopsy, so that you can get a diagnosis, right? Don't keep patients there on ARVs for years, and you find that you are referring them too late. So the principle is to investigate, get to a specific diagnosis, so that you can provide specific treatment, start them on ARVs, and then immunosuppressive therapy, as per the advice of a nephrologist, for a lack of a better word. All right. So in terms of starting ARVs, you need to be able to classify your patients as either low risk or high risk, right? If your patient is low risk, their creatinine clearance, is high. If you are able to do your urine protein creatinine ratio is less than 200, and it's a younger patient, you should be able to start them on TLD or TEE with tenofovir without any worries. But where you have classified your patient as high risk, either because they've got comorbid conditions, they're hypertensive, it's an older patient, they've got a low weight, maybe you should avoid starting tenofovir in the first place and giving them an alternate better regimen, which is a kidney safe or renal safe. And that is how you would approach these kinds of patients. I won't go through this, but I want to emphasize just that top. When you get the slides, you look at it into detail to say, if your patient is low risk, you can monitor them once a year, your annual, and this is important. Remember, our basic HIV guidelines in the country are generally written for a low risk patient with a normal creatinine who's young, no comorbid. Once you have a high risk patient, you cannot follow the basic HIV guidelines and they say we must do a creatinine once a year. No, you are dealing with a diabetic who's hypertensive, he's got high cholesterol, he's 60 years old, his weight is 49, he's a very sick patient. You would rather do it every 6 months. And this is what we call differentiated care, where now the care, we don't treat everyone as if they are low risk, but we do it. according to how you classify your patient as either having basic HIV issues or advanced HIV disease. So at a high level, make sure that all patients are screened for kidney disease. Make sure that you have a monitoring plan for each patient based on their risk. Then make sure that where it's needed, refer to nephrology as early as possible. Don't keep patients with kidney issues for long at the clinic, at the district hospital. At least make a call, discuss with a physician, nephrologist, so that then you can be able to get proper advice, for your particular case. All right. So as I close, just this last 3 bullets to say, are there any investigations that you can do? Yes, which are helpful. If you are dealing with a very sick patient, the blood gas might need to be done to see if they're becoming acidotic. And ultrasound is useful. Remember, if there's stones, but also the size. If the kidneys are small, kidney failure with small kidneys, you can think of something like hypertension, atherosclerosis, whatever, issues. But kidney failure with large kidneys, diabetes, HIV-associated nephropathy, amyloidosis, polycystic kidney disease. So, it helps to say, okay, I'm having kidney failure with small kidneys versus big kidneys, and it helps you with your differential as well. Check, your hepatitis viruses, check your vitamin D, you exclude autoimmune disorders, blood cultures, very useful, but you can do them specific to a patient. Now, in terms of your initial management of a patient, always assess the fluid status. It's very important. What is the heart rate? What is your patient hypertensive or normotensive? If you have a raised JVP, I'm sure the clinicians hear me there, skin togger, capillary refill. So get a sense of, are you dealing with a patient who's got a lot of fluid in their body, therefore you need to be very cautious, or they are depleted, therefore you need to rehydrate them. So if they are fluid depleted, they need fluids, right? 500 mils normal saline over 30 minutes as your first start, and then you maintain from there. If there is fluid overload, you might need to give morphine. It's quite helpful because they become less anxious. It's also a vasodilator, and if they're in pain as well, they'll get all the benefits. You might also want to start some diuretics. If your patient has a high potassium, we need to deal with that 10 mils of 10% calcium gluconate, with insulin and dextrose. Sometimes, depending on their response. If you don't have that, sometimes from a clinic to a hospital, nebulize them with salbutamol. Hopefully, when they get to the hospital, we can do some of these things. If the signs of infection, maybe treat, with an antibiotic. Stop any nephrotoxic drugs. It doesn't matter what you think, whether you think it's TDF or not, but if you're dealing with a patient who's got kidney injury, it's best to stop. Then you'll consider reinitiating later on. And then if there's a specific cause or contributor, hypertension, let's control that. If there's diabetes, let's optimize the treatment. If there's obstruction, let's deal with that particular cause at that point in time. In terms of fluid management, I think it's important to know that at any level, from home to the biggest hospital, fluids can be managed. At home, it's oral, rehydration. It helps. You have seen children on an oral rehydrated, just becoming better, right? Also, it's important to know that when you are resuscitating or maintaining, these two things are not the same. If you are resuscitating, your patient needs a lot of fluids. Probably you are calculating it based on their JVP, or they're combining it with their urine output and their weight, trying to see, what is best, But once your patient has been stabilized and you want to maintain, you then usually rely on your input-output chart. So you look at how much did your patient take in, to calculate what you're going to give to your patient, you check what they've taken out, you measure the output, you add 500 mils. And then if you want to do it hourly based on their hourly input output, it's also possible. You take the hourly output, you add 25 mils, and that's what you need to replace all the time. This is now maintenance, right? But remember, if you need to resuscitate, then you need to respond based on the blood pressure of your patient, your JVP, and how your patient is looking. Yeah. So be alert as well of the polyuric phase. Some patients, when they're in acute tubular necrosis, they can actually pass a lot of urine. And remember, I also said tenofovir can also cause the failure of the kidneys to reabsorb water, right? And then they pass and pass and pass and pass. Nephrogenic diabetes insipidus, quite important. So as we close, coming back to our case, I don't know if you have changed your mind at this point in time as to what is it that we need to do with this particular basic case. So let's go back to our initial poll. Let me relaunch it and see. Yeah. So it's a 27-year-old female who comes with diarrhea. She's got a CDV count of 95. She was recently started on TLD. She's got a high potassium and rising urea and creatinines. Does she have acute or chronic kidney injury? Let's all participate. I'll give you a few seconds to do that. All right. 5 more seconds. I'm stopping and I'm sharing with you, and you can see I'm happy that the percentages have improved. 71% you said acute. There's signs of acuteness here, right? I presume when she was started on ARVs, she was stable, right? And today she's not well. So recent history, there's diarrhea, there's the potassium, which is high. Remember, potassium tends to be high in acute kidney injury than chronic kidney injury. So I agree generally with those who said acute kidney injury. In terms of your management approach, may I check if you have a different view at this point in time? Your initial management, what are you planning to do? You may choose more than one option. Let's all participate. If you can't choose, you might want to type in your answer there. All right. Yes, so let me show you the results. So stop TDF, yeah, it's generally encouraged that if you have a patient who's rapidly deteriorating and they have some kidney injury, maybe stop all the nephrotoxic drugs. But remember, DTG is not nephrotoxic. It might contribute to an increasing creatinine, which is stable, right? But this is abnormal. Everything we're seeing here, the high potassium, DTG does not cause that. Rehydrate the patient. Yeah, so classify, is this acute or chronic? How bad is it? Is this a patient who needs to be admitted? Can we rehydrate at home? Does it need a drip? Does it need a CV line? Does the patient need dialysis? It helps you with that. Investigate the cause. Are we dealing with a shock, pre-renal? Is the direct kidney injury, or are we dealing with an obstruction, and you deal with that? So the most likely options here are to stop TDF, maybe rehydrate the patient and classify. But with stop TDF, please be very careful, because we have a secondary cause here, which is diarrhea, right? So if the cause of the renal impairment is the diarrhea, maybe rehydrate and see. And if after rehydrating, your patient's kidney does not improve, your urine, your UNE results are not improving, maybe then consider stopping TDF. So there's just a thin line there, because we already see that there is a secondary cause of some sort for our patient. All right. So this is how the approach to that case, right? If there is established kidney failure, we should stop TDF. And that is what I was trying to say, it seems like there's an underlying cause. So maybe let's rehydrate, correct what we can correct and see. And if everything is resolved, maybe there's no need to stop TDF, right? You generally have two options to either stop all the drugs. This is in the context of an established kidney failure, right? Or substitute TDF to an alternate beta drug like abacavir, and we don't need to cover the tail or do anything. So those are the two options. Do you stop everything or do you stop TDF only? In this case, I would resuscitate the patient, repeat the UNEs. If they are still the same, switch TDF to abacavir and see what's going on. Remember, she's got HIV. The CD4 count is 90 with a high viral load. You still need ARVs to control that virus. So quite important as well. And then if you have stopped, how do you restart the ARVs? So if all ARVs were stopped, right, you can restart them once the kidney functions have normalized and you start all the three drugs at the same time, right? If a patient on TDF gets acute kidney injury and for another reason, like a dehydration, or we find that there was another infection, it is safe to introduce. So you can still reintroduce TDF after kidney injury if the cause of the kidney injury has been identified, right? The secondary cause. Also try to make arrangements for close monitoring. Remember, we discussed this, that all your high-risk patients, you need to monitor them very closely. After switching back to TDF, you want to repeat your creatinines maybe after 2 weeks, after 1 month, and then you take it from there based on how your patient is going. All right. So I will share the slides. You will find this nice algorithm as well around kidney injury for patients taking tenofovir. You know, if the creatinine current is less than 50, it gives you advice to say stop TDF, consider abacavir, investigate for other things. So it's everything that we have discussed, but summarized in one snapshot, which you would want to follow, right? And then, yeah. So, yeah, interesting. I thought I was still continuing to teach. It seems like we are done. So I just want to appreciate some of the people who have contributed to this particular knowledge, which I'm sharing with you. I will just go through the chat. I see there is a comment. Butole Zwenyati. You are saying, Doc, I see on your results you left EGFR, and I usually look at it. What is the significance of GFR in the results? We usually encourage a lot of water, 2 liters a day, and then repeat a creatinine in 2 to 3 months. Is that correct? Okay, let me deal with your first part of the question. I did speak to it, and I said particularly that you must always remember that your estimated glomerular filtration rate, the calculation there is based on your creatinine, the weight, and the gender of your patient. And I said a creatinine would only start to increase significantly when the patient has already lost 50% of their kidney function, right? So in saying that, I was saying a screening by creatinine on its own or EGFRs is not enough. You know, you have to take proper assessment of the history of your patient, comorbid conditions. Are they hypertensive, diabetic? Do they have protein in urine? If you can do that, spot albumin protein, urine protein ratio, even better. But in the government sector, we rely on the creatinine and the EGFR, right? Yes, most of the time, patients would present with rising creatinine levels because they are dehydrated, either because of it's hot or they've lost fluids. And then advising them to take lots of fluids is a good thing. But repeating it after 2 to 3 months, you know, might be a bit too long. Imagine if the creatinine, the EGFR, is 30 or 15. We can't, 3 months is too far. And ideally, if the creatinine clearance is less than 50, you know, that patient needs to be discussed with the doctor. If you are the doctor, you probably need to investigate, classify, investigate, find the cause, try to correct with IV fluids, you know, because kidney injury, once it happens, you can't really reverse much of it. So we want to intervene early. right there. But I know of this practice, and it's mainly because in the public sector, especially the rural settings and the clinics, there isn't a lot of support. And these patients, I can tell you, there are many. Hence, you don't have that appetite to refer and investigate all of them. So giving your patient a chance to rehydrate and then repeat, it's a good thing. Maybe see them after a month and repeat rather than 3 months. And then you are saying, how can the storage of the blood specimen affect the result? Yeah, so if there's hemolysis, maybe you collect today, the specimen is collected tomorrow, it was not stored properly. Hemolysis can give you high creatinine levels, it will give you high potassium levels, it will usually generally false positive results. So you might want to make sure that the specimens are handled correctly, but usually the lab will tell you that based on these values, we suspect that there was cell destruction or hemolysis. Please repeat the specimen so that you can interpret it correctly. So I hope, Buthelezwe, you are happy with that one. Funekwa, thank you for the question as well. You are saying, under which circumstances would you reduce the dose of TDF in a patient with renal failure? Or must you always stop it if there are other causes? Okay, so the way you approach it, Funeka, is as follows, right? Let's say you have a patient who has started on TLD and they have this rising creatinine and a decreasing EGFR or creatinine clearance. The guidelines really recommend that you need to switch and stop TDF, and that is at the basic level. So HIV care has levels, right? At the basic level, that is the public health approach, which minimizes a lot of referrals and a lot of investigations, right? But in the advanced clinical care program, now we are trying to help you to understand better and to say, I can actually stratify my patients and decide which patients I'm switching, which ones I can keep, monitor, and then, and so on. So where you have a patient who's got renal failure, they've got hepatitis B, for example, they've got two conditions, right? One is that hepatitis B requires that tenofovir and lamivudine or emtricitabine, that those two drugs should not be stopped, because if you stop them, your patient gets this rebound viral rebound. A high hepatitis B viral rebound. They come sick, jaundiced with their hepatitis, and really sometimes they don't even do well, right? So that's what we're trying to avoid, that kind of a scenario. So in not stopping TDF in that instance, but now your patient develops acute kidney injury, what do you do? There's a number of things you could do. You could still stop temporarily. So stop TDF maybe for a week, deal with the kidney issues, optimize, rehydrate, and when your patient is okay, restart it, or even refer to a hepatologist to consider other treatments for hepatitis B. So those are some of the options. But all in all, what I've seen being done in some of the ICUs is to give, especially in the context where the patient has renal failure from another cause. So if I was to give you a scenario, it's a patient, HIV positive on TLD, develops renal failure, also has hepatitis B, right? So obviously, your initial management is to optimize the patient. You might even stop TDF temporarily at that point in time. But if it comes back that the cause for the renal failure is, dehydration, for argument's sake, you are allowed to restart TDF even if the kidneys have not fully recovered, because you know that the cause of that injury was not TDF. So usually we would continue TDF in a patient who is who's got failing kidneys, where we are put in a corner, and more than half the time it's got something to do with hepatitis B and HIV co-infection, But all in all, the public health approach in the country is that if a patient is taking TDF and their creatinine clearance drops below 50, you should switch them from TDF and give them abacavir. That is what is done at the primary care level. At the hospital level, at an advanced care level, we have to investigate the cause optimize the patient, treat the cause. If the cause is TDF, therefore you will not start TDF again. If there's another secondary cause, TDF can still be started. I don't know, Funeka, you let me know if that covers the issue there. And then Kate, it's Katie. I'm hoping I'm pronouncing your name nice. Katie Mukwena. What do we do in a, yeah, and that was the scenario, Katie, patient who's got hepatitis B and renal failure. It depends, right? If the patient's renal failure is caused by a secondary issue, you could easily stop TDF temporarily, deal with the renal issues, and then start it again. Remember, the rebound doesn't happen in days, though my one case probably happened in like 5 to 7 days. She came back really very deeply jaundiced. And this particular case, it was during the switch from first line to second line, where we had failed to pick up that she's got hepatitis B, and she came back with deep jaundice right there. So in a patient with hepatitis B and renal failure, if you are forced to keep TDF, you are going to give the renal doses of TDF. So you can still keep TDF in the regimen. Let me show you the slide, because I think we covered that particular slide. You can still keep the TDF, and then you prescribe your renal dosing. So here we are. So if the creatinine clearance is between 10 and 29, you would give tenofovir only twice a week, and then or every second day if the creatinine clearance is between 30 and 49. That is how you would deal with it. All right. So yeah, I hope you are okay, and I hope this session was worth your time as well. We still have maybe 2 minutes, no, 3 minutes or so. If you still have questions, you may even raise your hand. I don't know, anyone who wants to make a comment or a question? Okay, Funega, you are happy. Leta, you are happy. All right. Any other questions or comments? It was the HIV and the kidney. I hope you have managed to grab something. Yeah, so in the meantime, just remember that next week we are going to talk to HIV and the skin conditions. I know it will be on a lighter note. I know today's session had a lot of theory behind it. If you're going to write the diploma, I can tell you there will be a question on HIV and the kidney, particularly with the drugs, your TDFs and stuff, your TEFs. So these are things that you need to master, right?